I'm going to focus on primary headache syndromes today, particularly migraine and tension type headache, since they are the most common forms of primary headaches that we'll deal with in practice. So here's the entire population, and 90% have had a headache, and 75% have had episodic headaches, and 50% have had severe headaches. 25% have recurring severe headaches. 12% of the population has the International Headache Society criteria for migraine, and 4% have chronic daily headaches. So by far, most of the headaches that people present to us as headache doctors have primary headache syndromes rather than secondary headaches. So here is the general epidemiology of headache. By far, most people with recurring headaches have tension type headaches. 78%, and 12% have the criteria for migraine, and everybody else is a small percentage of people. Now, the disconnect here is that although tension type headaches are by far the most common cause of recurring headaches, if you're a headache doctor, we never see these people. They never come to us for care because, as you'll see, tension type headaches by definition are mild, people self-treat, and they don't need any of us. So if you ask the question differently, if you come to a doctor with a complaint of headache, by far most have migraine. So here is the American Migraine Study 2 dealing with tension type headaches, pointing out that tension type headache is by far the most common cause of headache that presents to a doctor, that nearly everyone gets these types of headaches. The prevalence is most common in the 4th and 5th decade, but that's not terribly important because it can occur in any age as well. And there are several types of tension type headaches in the ICD-10 classification. I want to point out that some are infrequent and some are frequent, some are associated with pericranial tenderness, and some are not. So these are the criteria for infrequent episodic tension type headaches. Basically, less than 12 days per year, so they don't occur very often. They last 30 minutes to 7 days, and then you have to pick 2 of the following criteria, at least 2. They don't have to all occur. Bilateral, pressure-like headache, mild or moderate in severity and not increased by routine activity, and then you have to have both of these, no nausea or vomiting, although you can be anorexic, and no more than photophobia or phonophobia. In other words, you can't have both. And if you look at these criteria, and next I'll talk about migraine, you'll see that the criteria for tension type headache are basically, it's not migraine. Then there's a frequent episodic tension type headache. These occur 12 to 180 days per year, the same criteria for the individual attacks. And then there's chronic tension type headache, basically occurring at least half the year, and again the same criteria for the attacks. Now, when I started out in headache medicine in the late 70s, these were called tension headaches. And this was a clearly very ambiguous term because I recall polling doctors in a meeting, and half of the doctors said that means that the patient is very tense, and the other half said that means that the muscles are very tense. And it was clearly very ambiguous. So the experts at the time changed the terminology to muscle contraction headache. Well, that didn't help much at all because it turned out that frequently their muscles weren't contracted, other times they were contracted, and furthermore, whether they were contracted or not, or how contracted they were, didn't correlate a bit with the headaches. So the concept of muscle contraction and tension headache didn't fit. So the term was then changed to tension type headache. I'm not sure that's helped us a lot, but that's the terminology that we currently use. And in episodic tension headaches, again, there's little correlation. In chronic tension type headache, the EMGs of suboccipital muscles do tend to be a bit higher than controls. So let's go to the psychological factors. If it's not muscle contraction, what's the deal? Well, they're associated with stress, no question about that. That could be a major trigger for tension type headache. And even more so with the sort of typical hassles of life that people get when they have these headaches as well. There's no more depression when you have episodic tension type headache than anyone else, but there is an association of depression in those with chronic tension type headaches as well. And also, major depression can present with tension type headache. Chronic tension type headache, as opposed to the episodic form, is associated with panic disorder and general anxiety disorder. Unlike migraine, tension type headaches do not appear to have very important genetic underpinnings. In fact, with chronic tension type headache, there was some increased risk of genes impairing studies, but not in the episodic form. And so what we have to conclude in terms of tension type headache is that the genetic underpinnings are either weak or don't exist at all. So let's go back to the American migraine study done by Richard Lipton. There were actually two of these. First one was in 1989, and then it was repeated 10 years later. And in 1989, it was recognized that only 38% of people with migraine were getting diagnosed as having migraine. So there was a lot of education at that time to increase the understanding of migraine by healthcare providers. And 10 years later, the number went up to 48%. So here we are at a time where we recognize that only half of the people with migraine were getting diagnosed as having migraine, which begged the question, if they weren't getting diagnosed as having migraine, what in the world were they getting diagnosed as having? Turned out that 32% of the time these migraineurs were told they had tension headaches, and 42% of the time they were told they had sinus headaches. And if you look at the slide, you have to recognize this is clearly the American migraine study, because the concept of tension of sinus headache is really some American thing, and you won't get this diagnosis outside of the United States. So clearly this is an American migraine study, and unfortunately you have to recognize that much of the world is laughing at us over this diagnosis, or certainly overdiagnosis of this sinus headache business. This is a primary care study done by Andy Dowson, and it was done in many countries except the United States, because it was recognized you can't do this study in the United States because everyone will be told they had sinus headaches. But basically the setup here is that people go to a primary care physician with a complaint of headaches, and a group of experts review the charts and assign a diagnosis. And what do they have? Well, it turns out 94% of the time they had migraine, or some form of migraine. So again, if you go to a primary care office with a complaint of headache, odds are by far that you have migraine. So what are the pitfalls? Well, a lot of the pitfalls come from things that we learned incorrectly. For example, I still hear this term vascular headache thrown around quite a bit, and in the opinion of many doctors, it's synonymous with migraine, which is an outdated concept. And then the idea of tension and muscles fit together, which is again an outdated concept. And if you have nasal symptoms with your migraine, people say that must be a sinus problem. And also patients direct us. We see that, or they lead us. It's my allergies, so people figure that must be a sinus headache. It's triggered by stress, oh, that must be a tension headache. Or it's my sinuses, again, it must be a sinus headache. Also recognize that when people are treated, particularly partially treated, many of these headaches kind of sound alike, and the symptoms of the attack may be very blunted. So let's go to migraine. And these are the ICHT 3B criteria for migraine without aura. Now, migraine without aura makes up about 80% of cases of migraine, and here are the criteria. You need at least 5 attacks. What that means is the first few times you can be pretty certain this person has migraine, but you can't officially diagnose it as migraine with or without aura. So 5 or more attacks that last 4 to 72 hours, and then you have to pick at least 2 of the following. Again, you don't need all, just 2. Unilateral, pulsatile, moderate to severe, and worse with routine activity. And being worse with routine activity is actually the most sensitive question for migraine. Not the most specific, but the most sensitive test for migraine. And during the attack, you have to have at least one of the following: nausea and or vomiting. And if you pick the second one, you have to have both photophobia and phonophobia. So again, contrast this to the criteria for tension type headache, which basically says it's not migraine. Now there's migraine with aura, and that makes up about 20% of cases of migraine. You have to have at least 2 attacks. A very odd kind of classification, if you ask me, because you can have many, many attacks without aura and 2 or 3 with aura, but your diagnosis remains migraine with aura. And then you have to have 2 or more of the following fully reversible aura symptoms. And I think this is a major advance, because before we made a big distinction between visual aura and other types of auras, which physiologically really never made a whole lot of sense. So visual, sensory, and I'll amplify what I mean by these: speech or language, motor, brainstem, or retinal, meaning it's actually in an eye. And then you have to have at least 2 of the following 4 characteristics: at least 1 aura symptom spreading over at least 5 minutes, or 2 or more occurring in succession, each one lasting 5 to 60 minutes, at least 1 aura symptom being unilateral, and the aura is accompanied or followed within 60 minutes by headache. So again, you don't need them all, you have to have at least 2 of the following. So let's go back to the sinus story for a second. This is called the Summit study, done by Kurt Schreiber. And it's rather an interesting study because it's a large study enrolling over 3,000 patients. And the setup here is that these are people with either self-diagnosed or physician-diagnosed sinus headache. And it turned out, with further review, that 80% of the time they had migraine, 8% of the time they had migrainous, meaning migraine minus a feature, 8% of the time they had tension headache, and everyone else was a very small percentage of patients. So then the question is, since we seem to believe so much in this country about sinus headache, where does this come from? Where are these autonomic symptoms come from, and how prevalent are they? And here's a study by Barbanti, who looked at when people get autonomic symptoms for migraine, how frequent are they? Turns out nearly half the time migraineurs get autonomic symptoms, and what do they get? They get eye tearing, nasal congestion, or both. So here are the criteria for sinus headache derived by the tooth fairy. And I think it's easier to understand this if you recognize a reflex called the trigeminal autonomic reflex, which neurologists talk about quite a bit. And it has to do with synaptic connections with the trigeminal nerve and the autonomic system. So you may never have heard of this reflex, but you've probably experienced it. If you go to an Indian restaurant and you eat hot vindaloo, or a Chinese restaurant and eat hot Szechuan food, or even go out in a very cold day with cold air blowing in your nose, your eye will tear, your nose will run. You're not allergic to the cold, and you're not allergic to that food. You've activated this trigeminal autonomic reflex, and that's why you get eye tearing and nasal congestion. So I want to tell you about a case. It's a case of a 25-year-old woman came in with a constant headache, which was bilateral and all over her head. And then she said to me, twice a week I have this other headache, and it's pulsatile, and I'm completely disabled. And the only thing I found on exam was that her neck was tight. So at first glance, this would sound like a tension headache. Let's go on and review that. Pressure-like headache, bilateral, not worse with routine activity. And she wasn't terribly sick with it. Well, here's a piece that was put out by a pharmaceutical company a number of years ago. I immediately made a slide of this because I found it very interesting. They were actually selling a drug for tension-type headache, and they described this bilateral constricting band-like headache, but they never mentioned, what's that thing in the eye? A lot of people come in and they say, my migraines start like a tension headache and they wind up like a migraine. Others say, no, my tension headaches start like a migraine and then my muscles are very tense. Well, many years ago, Dr. Raskin in UCSF said they're all the same. And he talked about a headache continuum, describing migraine with aura on one end of the spectrum, chronic tension headaches on the other end of the spectrum. But he pointed out to us many years ago, it's no coincidence that people talk about so many different kinds of headaches. And you've seen these people come to your office saying, I have 8 different kinds of headaches, which I would like to tell you about: my migraines, my tension headaches, my period headaches, my stress headaches, my oversleeping headaches, etc. Think of migraine as a continuum of types of headaches. And increasingly, we're thinking of migraine as simply a phenotype. I think when we're really smart many years from now, and we can talk about 2,000 genetic reasons why people develop this increased sensitivity, which we now call migraine, this will all make a lot more sense. So how about the neck? How does this tension headache and migraine business fit together? Well, it turns out that a lot of people with migraine talk about neck pain. In fact, 3/4 of people with migraine talk about neck pain, and it's often bilateral. So Bob Kanicki was interested in this and noted that a lot of people with migraine complain of neck pain, and then he asked the question, if you had neck pain with your migraine, what diagnosis had you received before you were referred to his headache clinic? Turns out that 82% of people with migraine who had neck pain were told they had tension-type headaches. So what occurs during an attack? And recognize that all of these systems can stop at a point, and you don't have to have the whole sequence. But commonly migraines begin with a prodrome, and prodromes can occur up to a few days before the attack. Maybe 20% have an aura, and then many develop a headache, most develop a headache, and then it resolves. But even after it resolves, people are typically not terribly well, and we call that a postdrome. Back in the days at Cornell University, near where I practice, there was a neurosurgeon named Bronson Ray, and people would go there, and he got very interested in what was the structures in the head that caused migraine or triggered pain. And what he did was he did craniotomies and stimulated various parts of the head, and found that the brain, when stimulated, didn't induce pain, but a lot of the extracranial structures and the meninges in particular triggered headache. So he said, this must not be a brain problem, actually. It must be a blood flow problem, because the extracranial arteries were very sensitive to pain. So they came up with this theory that many of us learned in med school. I certainly was taught this in medical school, that migraine was a vascular headache. And the idea was that during the aura, there was vasoconstriction, so you didn't get enough blood flow. During the headache, you had too much blood flow, and that was the vascular headache that many of us learned about in those days. Well, here's a study by Jess Olofsson, who showed that there was hypoperfusion in a migraine, followed by hyperperfusion, which made a lot of sense. But if you looked at it more carefully, the aura started during hypoperfusion, but the aura disappeared even though hypoperfusion continued. And in fact, the headache began during hypoperfusion and didn't change a bit as the brain went from hypo to hyperperfusing. And furthermore, the headache terminated even though hyperperfusion continued. So at minimum, you have to appreciate that the phenomena of hypo and hyperperfusion and aura and headache were not very tightly coupled. So now we think about migraine as kind of a hyperexcitable cortex. People with migraine simply have a brain that's more easily activated, just like asthmatics have an airway system that's more easily activated than others. And there are many lines of evidence to support this line of thinking. This is a study by Sheena Arora, 1998, who did a transcranial magnetic stimulation, placing a probe over the occiput of people and turning up the juice. And when you do this enough, people will see phosphines. They'll start talking about bright flashing lights, which are very reminiscent of what we see in migraine. The difference is that migraineurs see phosphines at a very low threshold compared to non-migraineurs. Much of what we learned about aura was from the work of Liao. About 70 years ago, he was then a graduate student at Harvard University, and he applied potassium and other excitatory amino acids on the cortex of rabbits, and a wave occurred, going from the back to the front of the brain at about 3 millimeters a minute. And it activated neurons and then left them in a refractory period. And we now call this cortical spreading depression. And you'll often see CSD as perhaps a major feature of migraine, certainly migraine with aura, but perhaps migraine in general. So if you activate the brain with these lights and lines, you get activation of what are called linear receptive neurons. And if you do this to a normal person, you'll see activation of the primary visual cortex. But if you do this to a migraineur, you get activation well beyond the distribution of the primary visual cortex. So there are different ways of putting this together. Perhaps cortical spreading depression causes updiffusion of a variety of chemicals onto the meninges, excitatory amino acids, nitric oxide, calcitonin gene-related peptide, for example. Now, the meninges are very sensitive to pain, and if you actually see a patient with meningitis and you see a patient with bad migraine, other than the fact that the cause is different and migraineurs don't have a fever, you'll see that the features of the attack are very, very similar. Now, the meninges, being very sensitive to pain, are largely innervated by the first division of the trigeminal nerve. So that information is signaled down through the first division of the trigeminal nerve into the second order neuron of the trigeminal system. And therefore, not surprisingly, the pain tends to be centered around the eye and the temple. Perhaps sometimes this information enters through the second division of the trigeminal nerve, which is around here, and perhaps if you had pain around here, and you had eye tearing and nasal congestion, and you happen to live in the United States, you might walk out with the diagnosis of a sinus headache. And sometimes perhaps this information enters the brain through the third division of the trigeminal nerve, and I've seen people with migraine go to dentists and being told they had temporomandibular joint disorders. Now, down here, we have this synaptic connection between the trigeminal system and the parasympathetic autonomic system through the superior salivatory nucleus. And this is when you can get eye tearing and nasal congestion. So the concept is that if you're perhaps genetically a migraineur and you're born with this heightened sensitivity, changes which are innocuous to other people may not be innocuous to you. And if you look at the triggers of migraine, they're actually rather mundane triggers. And probably all of them would trigger a headache in anyone, except migraineurs have a low threshold for the event, and therefore it doesn't take a whole lot to trigger a migraine in a migraineur. So whether it's internal, like hormonal changes in stress, or oversleeping or undersleeping, or external triggers like changes in weather, alcohol, missing meals, glare, flickering lights, etc., perhaps that will be sufficient in a migraineur to trigger an attack. Now let's go back to these prodromes, and we want people to recognize a prodrome because prodromes, which can occur even a few days before the attack, may give patients recognition that they're probably going to develop an attack, because what we've recognized in the acute treatment of migraine, that the sooner you treat it, the more likely it is to resolve the attack. So prodromes can be very subtle. Cold hands and feet, mood changes, a very common mood change is actually euphoria. Depression is common as well, but euphoria is really very common, and many people feel particularly well a day or two before their attack. And then frequent urination and other things could be a prodrome. Yawning is a very common one, and many people with migraine actually develop some cognitive impairment in general and tend to be blunted, and perhaps that's why when we tell them that they must treat early, they don't often recognize that they're developing an attack as early as we'd like them to. So we know that the dorsolateral pons and midbrain get activated during a migraine, and some people say that's the migraine generator. It's not clear that that's really the generator. We don't really know the answer. However, that certainly is associated with activation of that region and the development of cortical spreading depression. So let's go back to auras. Well, most of them are visual, and even though patients may have many kinds of auras, even in an individual attack, almost always they do have a visual aura. So 99% of migraines with aura are visual, and 64% of the time they're only visual. And visual auras vary widely. They can be colored, they can be uncolored, they can be part of a positive phenomena like bright flashing lights, or negative phenomena like blind spots. They can be sensory, tingling, often followed by numbness. Chiro-oral is very common, meaning hand and lips. That's nearly pathognomonic of migraine. Motor auras can occur as well. You can develop aphasias or dysarthrias. You can develop very odd syndromes, often having to do with parietal lobe symptomatology, like neglect syndromes. You can have palinopsia, which are after images, achromatopsia, which has to do with color vision disappearing, transient global amnesia. Some people believe may be related to migraine as well. And you can develop many of these in succession. And don't forget what are called acephalgic migraines, which are auras with no headache to follow. Please remember, you don't have to have every one of these symptoms to have a migraine. And Lashley was a neurologist with migraine, and he had typical tachopsia, which are these zigzag lines. And being a compulsive neurologist, he noted that it was here, 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 and here. He knew where these events were in his visual cortex. He did the math, and he said, this event is moving across my cortex at about 3 millimeters a minute, which of course is the same speed that Leow described cortical spreading depression. He also noted two components of his aura. There was a central blind spot, and as it enlarged and moved across the visual field, it was kind of a zigzag outline. And I think if you understand how this is activating linear receptive neurons in the occiput, this kind of outline makes more sense to you. Now, it is thought that there's a big distinction between migraine with aura and migraine without aura, and that's not entirely worked out at this point. And this is a study by Woods looking at blood flow, and this particular case was of a patient, it was assumed, had no aura, although that was argued. But whatever happened, there were changes in blood flow which were quite dramatic going across the cortex. And even if you accept the fact that this patient maybe had a vague aura or whatever, the extent of these blood flow abnormalities was beyond the distribution of the clinical phenomena that the patient might have described. So there may not, at the end of the day, be quite as dramatic a difference between migraine with aura and migraine without aura, as we've talked about. Here's a few more auras. This is called mosaic vision. And this is called metamorphopic migraine, change in the size and shape of object. And maybe it's a story, I'm not sure, but it's often said that Lewis Carroll had metamorphopic migraine, so we often refer to this as Alice in Wonderland syndrome. So when a patient has an aura, we particularly look for in the visual system something negative and something positive. Something positive meaning we've activated these neurons, something negative meaning the neurons are in a refractory period. Note that's what occurred during cortical spreading depression of Leow. So you see this blind spot and the outside tachopsia, which is in this case colored. And this gets larger and larger as it crosses the visual field. Now, at some point, if it doesn't go away, you get what's called central sensitization. And at this point, it's entered the brain. It's in the second order or third order neurons of the brain, the thalamus in particular. And what happens here is that the pain is not so well localized. And patients say, it's no longer in my eye and my temple, it's now everywhere in my head. And people often will report that they have something called allodynia, meaning things are felt to be painful with a stimulus that should not normally elicit such a painful response. So people will say, I hate the feeling of my glasses, I don't like the jewelry that's on my ears, I don't like brushing my hair, I take off my hat, things like that. That tells us this migraine is now in the level of the thalamus. You're now centrally desensitized. So leaving this vascular theory, things became more scientific by the work of Mike Moskowitz, who showed that there were neurons called trigeminal vascular neurons, which in fact innervated the blood vessels that we talked about, and taught us that they did a few things. That when the trigeminal vascular neurons became activated, they did lead to vasodilatation. How relevant that is isn't clear in terms of the headache symptomatology, but there's also a sterile inflammatory response. So that neurogenic inflammation is probably the link between the pain and other symptoms of migraine and the pain and other symptoms of meningitis. And furthermore, back when there was serotonin, it was really easy, but then it was recognized that serotonin was a much more complicated subject. There were many serotonin subtypes, and they had different functions. Those relevant to triptans, for example, are some of the 5-HT1s. Perhaps some of the preventive drugs work on some of the 5-HT2s, and we're beginning to learn more about the relevance of other serotonin receptor subtypes in migraine. So here's neurogenic inflammation. When one activates trigeminal vascular neurons, you can get release of a variety of chemicals, neurokinase, substance P, calcitonin gene-related peptide. These can fall onto the artery wall and make them vasodilate and swell. So going back to cortical spreading depression, this is an event moving across the cortex from the back to the front of the brain at about 3 millimeters a minute. So how do we put this neck pain and sinus pain together in a migraine? Again, what matters is where there are synaptic connections. And if you look at the trigeminal nucleus caudalis, it has neuronal connections with neurons from C2, C3, C4. And when they become activated, you get pain referred to the back of the neck. And the autonomic symptoms become activated, or the autonomic symptoms occur because of synaptic connections with the trigeminal system and the superior salivatory nucleus. So what are the chemicals involved in migraine? Well, there are several of particular interest to us. One is called calcitonin gene-related peptide, CGRP, and you'll be hearing a lot about CGRP going forward as several companies are developing monoclonal antibodies against CGRP or other small molecules that may interfere with transmission of calcitonin gene-related peptide. This is in fact the most important molecule, neuropeptide, released by trigeminal vascular neurons. And if you infuse CGRP into migraineurs, they develop a typical attack of migraine, and CGRP levels are increased during an attack in jugular venous blood, in spinal fluid, and saliva. What do? They vasodilate. How relevant that is to the physiology of migraine remains to be resolved. But there is meningeal mast cell degranulation. Mast cells are very prevalent in the meninges. These are easily degranulated, releasing a lot of vasoactive and pro-inflammatory chemicals. And then you also, with CGRP, get activation of second-order neurons in the trigeminal nucleus caudalis. Another is glutamate, and you'll be seeing drugs being developed to antagonize this effect. Glutamate is the most important excitatory amino acid in the brain, and it underlies cortical hyperexcitability. Cortical spreading depression is propagated by glutamate as well, and glutamate positive receptors are all very prevalent in pain relay receptors and pain relay centers in the brain. Last thing I want to discuss is, are migraines bad for you? You have to assume they're probably not good for you, but how bad they are for you remains to be seen. One thing is that migraine tends to progress. Many people with migraine, and although it's often blamed on their over-treatment of migraine, it can occur without over-treatment of their migraine, that migraineurs can get worse and worse and worse. There is an event called migrainous stroke, and people with migraine are at higher risk of developing stroke, and this stroke occurs typically not during an attack, but interictally. There's also persistent aura without infarction, and there's epilepsy. Epilepsy does occur in a higher rate in migraineurs compared to non-migraineurs. And iron deposition was found to be increased in the periaqueductal gray. This area that was claimed by some to be the migraine generator had more iron. And the iron wasn't the problem. It was a reflection of free radical cell damage in this region, perhaps again a model that migraines may not be good for you and somehow may cause some damage in the periaqueductal gray. Again, that remains to be seen how clinically relevant that is. And then finally, there are the dreaded deep white matter changes. I really discourage my migraine patients from getting MRI scans when they have very clear migraine. But if they insist, I give them heads up that frequently the scan showed deep white matter changes that are sometimes read out by the radiologist as strokes, which is very disturbing to them. And I tell them in advance that these are often very commonly seen in migraineurs, and the clinical relevance of these, again, remains to be seen. So we've covered the physiology of the two most important primary headache syndromes, and for more information, check the references at the end of this tape.